All right, looks like it's 2:02. Got about 50 folks on the line. Let's get started. So great to see everybody again. And for those who are newly joining, welcome. My name is Keith Coker. I'm an emergency physician at the University of Michigan and one of the medical directors of the medic program. We are hosting the seminar series on ending the HIV epidemic, focused in particular on developing screening programs in emergency departments across the state. Um, I'll kick things off here with just some standard kinds of notes. Give me just a second while I share my slides. Um, so we'd really like to know who you are. If you can make sure that your name's in the Zoom. Um, if not, let us know afterwards just to make sure that we can give you credit for being here, and particularly related to CME. Certainly, if you're able to be on video, that'd be great. We want to make it as interactive as possible. If not, we certainly understand. And certainly, if you want to ask questions, please use the chat function, and we'll make sure we have time to get to questions along the way. There are a couple disclosures to note, just for CME reasons. Both myself and Kristen Swore have some grant support from the Department of Health and Human Services to support this work, and in partnership with them in supporting the seminar series. So here's the agenda. We're going to really talk through the roles and responsibilities and perspectives of developing and implementing these HIV screening programs in the emergency department. I'm going to start off with 10 or 15 minutes just providing some kind of high-level orientation to the emergency department as a care setting. I think one of the things we recognize as we've done a number of these learning series as, we're attracting a lot of folks who are outside of care delivery in the ED. We thought it'd be helpful to level set on, what it's like to operate and work within the ED setting. And then we'll turn things over to Kristen Swore, who's you've heard from before. If you've been here before, she's an emergency physician at Hurley, and the leader of their own HIV screening program. And she is going to tag team this with Jenny Cunningham, who is a nurse manager in that emergency department as well. And we'll have some time for question and answer, as I already described, and then we'll wrap things up. Okay, so let's talk about the emergency department. Um, you know, as you think about the emergency room or the emergency department, this might be one of those images that comes to mind. Wouldn't be surprised. Or maybe it's, something like this. Certainly, waiting and boarding is frequently encountered, and maybe, an image that comes to mind pretty often. Maybe it's something like this. Um, you know, Certainly the bills that come from emergency departments can be scary. People worry about this a lot. Well, as somebody that works there, one of the realities of the emergency department is it's similar to, like, that metaphor you hear about regarding an elephant. It just kind of depends on your perspectives and what part of it that you see. It plays a whole lot of roles in the healthcare setting. I've listed a few of them here. A diagnostic unit, safety net, a cost center, a public health service, an admission lounge, standby capacity for disaster response. It's really all these things. But one of the challenges is it can't be necessarily all these things at once. It requires resources to support all these dimensions of how it's being used within our health system. And sometimes these roles conflict at times. I think at a high level, it's important to know that, it's a pretty common way for people to get healthcare in the United States. Um, Most recent data suggests there are about 150 million visits across the US annually, which is translates to about 1 in 2 people end up using the US in any given year. It definitely is a location where we spend a lot of healthcare dollars and resources. And increasingly, it's really the way that people get admitted to the hospital when they have, an unscheduled care reason or unanticipated health problem. Really, patients get into the hospital through the emergency department. I think one of the central kind of ethos of the ED is this sense of anyone, anything, anytime. I think people are called to this healthcare setting because they take this ethos to heart, um, and they believe that they are a safety net culture, in a location for people that need help when nobody else is available. It really is the only place in the United States where you can get healthcare 24/7 and every day of the year. We are federally mandated to provide an exam and healthcare for anyone that seeks that and crosses and asks for care. But at the same time, there is this triage mindset, and we approach care recognizing that there are time-sensitive healthcare needs that are going to have to take priority depending on what's going on in a given moment. Um, I think big picture, I think one way to, intuitively understand conceptually how ED operations work is this model around input, throughput, and output, where these are the dynamics that in any given moment factor into wait times and boarding and how quickly we can get to patients, how quickly we can move through testing and evaluation. Input being all those things that in ways that patients arrive to the emergency departments, walking in or ambulance services. Throughput being all the care processes that occur as you evaluate patients. And then output being, what ends up happening, discharge, transfer, admissions. I'm going to focus in particular on these two areas, throughput and output, just to kind of level set on how ED care processes work. And I'm going to talk about this in kind of conceptually as like constraints or realities or principles, sort of big picture, the things that may have limits around how ED care processes occur. So we'll take these one at a time. And this is within that group of throughput. So first, I think it's important to acknowledge, accept that there are these care processes, that there is this order of operations, there's a triage process, there's a prioritization process, which means that there could be some waits. One of the structural realities too about operating a 24/7 operation is that there's going to be some shift changes for nursing, for providers. And these are just the realities of having a 24/7 operation. There's this problem of boarding. Boarding is the term for patients that are admitted to the hospital, but there's no actual capacity, physical capacity in the hospital for that patient to be moved into an inpatient bed. And that means patients are in the emergency department still waiting for those beds. Another term for that is admit holds. There's a lot of system constraints that have nothing to do with the people working in the emergency department. This is sometimes the last resort for seeking care for a fragmented and dysfunctional healthcare system. There are realities around turnaround times for tests, blood tests, urine tests, different types of radiology imaging tests, getting specialty recommendations from consultants takes time. Certainly one of the blood tests that we're in the business of talking about is around HIV screening. And many of those tests don't even result same day. And you have to consider, what it means for that test to come back the next day. And of course, not everything, not all tests, not all specialists are available from the emergency department. And yet at the same time, the ED really is a highly trained and dedicated healthcare workforce. Another constraint is, just remembering that while we talk about individual patients a lot, um, the bigger picture is that there are many patients in various points of evaluation that are simultaneously being cared for. And it's not scheduled. And so you're at the whims of how patients arrive and the varying healthcare needs that people arrive with. There's not always enough physical space. Often care is taking place in kind of flexible areas like hallways or a chair or the waiting room. Sometimes care, is temporarily deprioritized when somebody comes in with greater healthcare needs. And so you have to work within that structure. But certainly everybody deserves high quality and safe care. So let's think about, some of the constraints around output. And this is at the point of admission or discharge. Communication is really important. It's the key oftentimes to healthcare safety and high quality care. But there's a lot of interference with good communication in the ED and being mindful of the need to sometimes mitigate against these pressures. The structural barriers, things like time pressures and interruptions, cultural and language barriers, incomplete documentation. These are all things that can interfere with the communication, sort of best ideal communication that you want. There's also the reality of what I'm calling diagnostic uncertainty, where you may do a lot of evaluation and testing, but it's common that you may not arrive at like the diagnosis. That a lot of care is oriented around ruling out sort of major problems, major emergencies, and oftentimes excluding those, but not necessarily arriving at the specific problem or diagnosis. And some tests, may not come back while you're in the emergency department. And so designing workflows around that is important. And then finally, the ED discharge is a transition of care. And there's always going to be a next step. There's always going to need to manage this navigation problem. And there's a period of vulnerability there, especially, as I think we'd all acknowledge, our healthcare system is imperfect and fragmented and sort of navigating through the social determinants of health limitations, the insurance status limitations, and sort of a lot of challenges into what that follow-up care can look like. And depending on your needs, solving that can be hard. And I think just kind of recognizing that there will always be these next steps and this need to navigate that follow-up and implementing the right kind of support and implementation to support that. So I'm going to stop there. Hopefully that provides some like level setting and orientation to ED care processes. Happy to take sort of questions and comments along the way. And certainly if you want to use the text function, like I said, I'm happy to respond to those. I'm going to hang things over though to Kristen here, who's going to take on the next section. So Kristen, the floor is yours.
All right, perfect, everybody. Let me just get my extra bars out of the way here. All right, my name is Kristen Swarwolf. I'm an emergency medicine doctor at Hurley Medical Center in Flint, Michigan. I'm also the physician champion for Medic in terms of the Ending HIV program. So today, I'm going to speak to you a little bit about how different people who work in the emergency department see and experience HIV screening. As Keith said, there's a lot of almost conflict of interest or limit in emergency department care. And while the overarching goal is to take care of any emergency, diagnose it, treat it, and make sure that people are given the care they need, the emergency department is also used for other reasons. And the fact that we have such a large catchment, the entire US healthcare population, allows us to do things like have important screening, like HIV screening, while we are still caring for people who are critically ill or people who are disenfranchised, people who have no other access to care. It's important, though, with all of these conflicts and all of these limitations, that any additional testing or program or any, little parts of the elephant, as Keith would put it, don't eat up the whole animal. So Hurley Medical Center is a 432 bed teaching hospital in the city of Flint. We're a level 1 trauma center and a burn center, as well as a children's hospital. We're a fairly large emergency department as far as scale goes. We have at least 75 emergency department beds at any given time. That expands based on the number of hallway beds and other factors where we are managing to squeeze other patients in, and more than 80,000 visits per year. We are in Genesee County. Flint's population is about 80,000, but our catchment includes Genesee County, which is close to 500,000. And oftentimes we are able to care for patients from the thumb all the way up to the tip of Michigan, given our northern location relative to other large hospitals. Our county HIV prevalence rate is 0.17%. And in the emergency department at Hurley Medical Center, in addition to the emergency medicine we provide, we also have an opt-out HIV screening. By this, we mean that anyone who comes to the emergency department between the ages of 18 and 64 who hasn't had an HIV test in the past year is eligible and will receive an HIV screen unless they opt out. This is a picture of the notices that are posted in all of our emergency department treatment rooms, from adult to the pediatric side, and in our triage areas, to advertise that we are providing this service. We do this obviously to diagnose people with HIV, to start treatment, to link them to care, to break the chain of transmission. But we also do this because making this a routine part of healthcare, especially in the emergency department where so many people arrive, decreases the stigma of testing for HIV in a disease that, not so recently was something that was very stigmatized, was very shameful, and that you needed specialized training, treatment, and counseling in order to test for. So it's a twofold program. A brief overview of our program. It began in 2019, and it is essentially an electronic medical record workflow that allows for this nearly automated testing. And we have the additional portion of that is posting of notices, like I said, about the emergency department that explain our HIV program. As I said, any patient between the ages of 18 and 64 who hasn't had a test in the past 12 months is eligible for HIV screening. So these are in addition to anyone in whom their reason for coming to the emergency department would require or suggest that they need HIV testing as well. So this means that in addition to someone who's coming in because they have had unprotected sexual intercourse, 6 weeks ago, and are concerned that they may have HIV and that person is tested, a 34-year-old who has a car accident and is having blood drawn will also be screened for HIV unless they opt out. The way it works is in the emergency department, when the patient first comes in and they register, they're then triaged by a nurse who asks questions about the reason that they're there, takes vital signs, and then there's a fairly lengthy questionnaire that oftentimes touches on other public health concerns. We have an additional triage questionnaire that is a disclosure of the HIV testing and allows for the individual to opt out of HIV testing. That occurs in triage, and if the patient does not opt out, then when the doctor or PA assigns themselves to the patient, an electronic medical record pop-up will come up to prompt them to order an HIV screening if the patient has not opted out. After the screen is ordered, patient's emergency department care happens as it would routinely without the HIV screening, and the patient may leave without those results. In the emergency department or with the disclosure of results, if they're positive, will happen either in the emergency department if the patient remains there when the test results, or with the Genesee County Health Department if the patient has left the emergency department and gone home when that test results. And the final phase is outpatient testing and treatment, which obviously is not part of the emergency department, but it's something with this program that we help provide a link to care. So from a physician standpoint, this is a little bit about what we'll see in our electronic medical record. If the patient who comes in from triage consents or does not opt out of HIV screening, an order pops up when a physician or a PA enters the patient care window. If that pop-up doesn't occur, the HIV screen can also be ordered manually. The patient, as I said, leaves when their treatment and testing for whatever they came to the emergency department, their chief complaint, is complete. And the HIV screen may still be in process. It can take a couple of hours. If there's a positive HIV screen and the patient's still in the emergency department, the emergency physician will notify the patient and let them know that they'll be follow-up and will likely link them to our infectious disease clinic. If the patient is discharged and a positive HIV screen is resulted, then our physician champion, who is myself, has a relationship with our health department to ensure that the patient is notified by the health department of their results. And this notification is done in a face-to-face manner by the health department and provides a linkage to care as well as appropriate counseling. So when this test is done and it screens positive, in the background, where the nursing staff and the physicians are unaffected, the lab will automatically add on a confirmatory test. The first test we do is a screen, meaning that there's a really high chance if you have HIV that test will result positive. But there's a there is a chance if the test is positive, there's a slight chance that it is a false positive, that the test accidentally said that you may have HIV without that being the case. So that's what the confirmatory blood test does. It confirms this very, very broad screen that says, yeah, it pretty much seems like this could be a problem for you. And it narrows down the testing saying, yes, indeed, this is a positive HIV test. The next step, again, out of the emergency department at Hurley Medical Center, is myself talking with the public health nurse coordinator or the disease intervention specialist at Genesee County Health Department and conferring any information about the patient to the health department that will allow them to get in touch with the patient. They're able to access our electronic medical records, so oftentimes transmitting the name and the patient's birth date securely, either by phone or secure email, or I guess fax, is a method by which we do this. So from the physician standpoint, if a patient is still in the hospital when there's a positive screening test, the emergency physician will notify the patient of their positive test as they would anything else. You have a fracture, you've had a heart attack, your HIV screen is positive. In that case, if the patient remains in the emergency department, oftentimes the infectious disease physician is notified if it's during office hours or daytime hours, who will recommend add-on blood work. And even when this occurs, the physician champion makes sure that the health department is aware of this. If the patient still remains in the ER, the emergency physician will oftentimes ensure that they have an appointment with infectious disease. And oftentimes that is just providing them the phone number of the infectious disease clinic and the physician talking to the infectious disease doctor and call, letting them know this patient is in the pipeline to ensure that they're not lost to follow. If you're the physician ordering the test and the test is positive after you have discharged the patient, it's possible that you may not find or follow up that test after you've gone home and finished taking care of the patient for the reason they came to the emergency department. And that's where our physician champion comes in, notifying the health department and, if needed, the infectious disease doctor if the patient wishes to follow up for their HIV care at Hurley Medical Center. I also order additional confirmatory and screening tests, testing tests for people who are confirmed to have HIV that allow them to start their treatment plan once that information is received by the infectious disease doctor. And I think that would make clear, we liaise with the health department to facilitate following up at Hurley Medical Center. And also because the health department will provide a face-to-face disclosure of the positive results, and we'll be able to counsel them about the consequences of the positive screen, the confirmatory testing, and what to expect in the near and far future as far as their healthcare is concerned. So just as a quick example, we're going to talk a little bit about a generic 44-year-old gentleman who comes to the emergency department complaining of chest pain. Now, this patient does not come here for concern for any infectious disease or HIV. But while in triage, after their vitals are taken and the patient goes through a screening questionnaire, one of these questions is, in this emergency department, we test everyone who is eligible for HIV screening unless they opt out. Is that okay? And that patient in triage did not opt out of HIV screening. They were treated for their chest pain, found not to have a heart attack, maybe a little bit of rib pain or costochondritis, and were sent home, but their HIV test was still in process. The next day, I received a daily report, which is a report that is triggered by our electronic medical record every 24 hours of the positive screen. And I notify the health department liaison, who then discloses to the patient face to face, calls them, makes an appointment, goes out and talks to them about the positive screening results and the positive testing. In the meantime, I've ordered some outpatient lab work and let our infectious disease doctors know to expect his patient, and let the health department disease intervention specialist know that the lab work is ordered and the patient can walk into any or the emergency department lab, offer their arm for blood, and not have to and get all of those results done before they get to the infectious disease lab or infectious disease clinic, expediting all of their care with lab draw and having all of the results available at their first appointment. This patient was found and disclosed their results, received counseling from the health department. They obtained their follow-up blood work in an outpatient lab from Hurley Medical Center that was convenient to where they were staying. And they were able to schedule and attend their first appointment with the infectious disease clinic at Hurley Medical Center, linking them to care for HIV that had not progressed so far as to have an opportunistic infection. It had not progressed to the patient transmitting that to anyone. And the patient was able to receive appropriate counseling to decrease the spread, appropriate counseling to start treatment and decrease any chances of having bad complications from an untreated HIV. So to conclude, opt-out screening in the emergency department at Hurley Medical Center is truly integrated into routine patient care. From a physician standpoint, and I believe Jenny will probably tell you more about the nursing perspective, but truly it has very little impact on the workflow of treating an individual patient or all of the patients that someone is caring for in the emergency department. It's a very streamlined process, and positive tests by our group determination are handled by one clinical champion so that the rest of the physicians can continue to provide their excellent emergency department care and discharge patients in whom screening is pending and ensure that they still have appropriate follow-up to those tests be positive. So my email is below. If anyone would like to take questions now, Keith, would we like to do that now or after the whole presentation?
Yeah, if there's questions now, fire away or put them in the chat. If not, we can certainly move on, and we will definitely have time at the end. Oh, there we go. I see several questions popping up. Yeah. Forgive me if I don't get your name right, but Claudia?
Yes.
Looks like you're
hi.
first. Yeah.
Yep. So, I'm a medical director at a health department in Detroit. How do I talk to, so some ED providers are comfortable embracing this, and then I'm sure your colleagues many times they are not, and the reason is, well, two reasons: fear of follow-up or challenges around follow-up, and then second is who's going to pay for all these tests.
Exactly.
Those are the
I'm
two
sorry.
things that I hear all the time. So I love, love, love the way you guys have organized your work at Hurley. It's really exciting. I mean, the word champion means so much in this space. The fact that you're interested and passionate about it means everything. But so it's hard to find a you in every ED. So, any thoughts or other than this space, are there any other spaces that ED providers gather where this conversation is being discussed? I mean, this topic is being discussed to help those of us in my position who come along afterwards I try to sell what the state, the state stance on. You do the test and we'll do the rest. Of course, we, can also have that. We do not have a program like with a physician champion with our local health department. So what you've shared today is certainly an opportunity, but also my conversations with the state have been, tell them if they do the test, we'll do the rest. But still there's the apprehension there.
Gotcha. Let me see. That is it. First of all, it's very nice to meet you. Let me try to address all of those, and you'll have to stop me if I don't get to everything that you had, because you had a lot of fantastic points. So part of the success of this program, I have to lend to, my wonderful administration and to the physician who originally piloted this program, Dr. Rademacher. One way we make this a routine thing where there's less resistance is actually just, I guess the testing doesn't only destigmatize HIV testing for the patient themselves. The more and more physicians that do it, the less and less of a stigma to testing, and the stigma of fear about follow-up occurs. We provide education at our staff meetings, and then occasional little email bumps or blasts to remind everybody about the program when testing decreases. So as more and more people, no one in the emergency department is required to order that test. So, if Dr. Jones decides that they do not want to test or screen anyone for HIV, there is nothing that compels that individual to order that screen, whether or not the patient opts in or out. They can choose not to do that. Our group has a pretty standard practice with this. It's become a routine part of our healthcare over the past 5 or 6 years. And there have been enough positive screens, positive tests, and linkage to care that our group has seen that there's just been some proof in the pudding where we have not lost a patient to follow up. I've got a wonderful health department colleague who is able to pretty much find anyone anywhere, and has done an amazing job of that, even in people who are very, very disenfranchised. And as far as payment goes, we did initially for the first couple of months have a grant to help get things off the ground. And this was before the MEDIC program started. And now most of the screening, in fact, all of it has been covered through insurance, whether it's public or private. We have yet to have a payer deny payment for an HIV screen.
Okay.
Ms. Claudia, does that answer and address some of your questions?
It's helpful, but I'll just say if you have any state meetings, and I'm sure there are others, would appreciate your advocacy.
Yes, so part of
Yeah.
what we are doing with our partnership with Medic and the Medic and Health Department partnership is exactly that, using the successful programs like ours and the one at Henry Ford, and using some of my experience to work with the Michigan Emergency Department Improvement Collaborative to spread the practice of HIV screening to as many emergency departments as possible within the state of Michigan. We are, let's see, close to a year into the program, and that's why we have our educational series. We meet from time to time with individual emergency departments or even healthcare conglomerates who are interested in starting this, and show them how it can be done and how it can be customized to their particular patient demographic, their particular lab testing system, their particular relationship with their health department to allow for a seamless and safe transition of care to anyone who may screen positive in the emergency department.
And my interest is also just to help move that also over to syphilis as much as possible.
Absolutely. And while that is not a part of our current program or mandate, I think that as the routine testing of HIV or routine screening for HIV comes up, and then the actual, the same test being done as a test as we, destigmatize HIV, we recognize that syphilis is on the rise, and people hear over and over again, if you can get gonorrhea, if you can get chlamydia, you can get HIV, you can get syphilis. They become a more and more integrated package of testing when people come in for certain reasons.
Yeah, I see how the comment about hepatitis C, I think that falls in the same consideration
Absolutely.
here. Yeah, I mean, I
That's
think just a little commentary from me and Dr. Swore is certainly the expert around implementation of a program like this. But going back to sort of what I was describing, I mean, there are going to be all these kind of constraints and operational challenges around implementing a program like this, and so you're going to have to solve those. I think it's unfair to expect an individual emergency physician to just do this on their own. I think you have to create the structure and the process that allows a program to succeed. And that is certainly what this program and this learning series is about. And so, Claudia, if you encounter emergency departments that may want to learn more, please send them our way because we want to develop these kind of partnerships to make it possible for others. I'm
I
gonna
think there's
okay.
Oh, I think there are
Okay.
some questions that are there that look like they may actually be very well answered by Jenny in her presentation, talking about the nursing perspective. Should we hold
Yeah, so we can
questions
move
and
on.
move to
There's
her section and then we can take questions at the
yeah,
end?
so I see one hand up, but just in the interest of time, and we will definitely get back to the hand, but let's move forward with Jenny's presentation here.
Thank you, everybody.
All right, thank you guys. And yeah, I did see some of those questions and I was thinking the same thing, that I can hopefully have some answers for you guys here shortly. So let me get my screen all together and we'll get going. Oh, so can everybody see my screen okay? And you can hear me okay, hopefully?
Yeah, it's not in presenter mode. Oh, there we go. You're
Okay,
good. Yep.
I'm gonna back it up though. For some reason it started at the end. Okay. So my name is Jenny Cunningham. I am the nurse manager in the emergency department here at Hurley. I work alongside Dr. Swore in the emergency department and help manage all these nurses in the department. So to kind of give you a better perspective as well, so I know Swore kind of gave you a general overview where we located and the population that we serve. And then I wanted to also point out, what does our emergency department look like? Because I started here in the emergency department when we were just a very small, all kind of bunched together, where the physicians and the nurses all gathered in one area. We built a new department and it's better than ever, but at the same time, we're also very spread out. So our physicians sit in one area and then our nurses sit at this area and this area, which is best served for their patient safety. But it really puts us into a more spread out way. So I can't really turn around and be like, hey, do you want, this lab test on this patient? Because they're not right behind us anymore. There's walls in between. A lot of the times, they're in rooms alongside of us and we can ask about that patient. But just kind of this visual perspective of where our patients will be and where they come in at. So this area up in yellow is kind of where I highlighted to show everyone. We, from a nursing perspective, do all of the HIV screening and triage. And I'm going to go over the question that we ask and like where it's built into our workflow. But the biggest takeaway kind of from this map is that when patients enter here, we pull them right into a room to get their vitals on them and everything. And then we're asking these screening questions. And sometimes they're getting back into a room. Other times they're going right back out into our waiting room, which fortunately isn't in this picture. But if they do have to wait, they'll be waiting out into our waiting room. Or we do have a lab room. So one other thing we just were able to kind of bring back recently, since we got back up to pretty sufficient staffing, is drawing some labs from our triage process. So that can also be one of the ones that can be initiated out in our lab room. So our nursing workflow. So from that map that I kind of just showed you, the nurse will bring the patient back and they start their triage assessment. So one thing, and Keith kind of mentioned it earlier in his PowerPoint, we're telling the nurses, it's really important to ask this HIV screening, but we also have all these really important other screenings that we need to ask as well. So we kind of start with arrival info. We have to get into any respiratory or COVID issues. We have a measles screening now because of our measles outbreaks. Our consent to treat, which is just general for our overall consent here at the hospital. And then we get into like our arrival documentation and then what are they really here for? And then we have to make sure they're not hitting anything where we need to initiate a code stroke and send them right to our CAT scan, our CT scanner. And then we're doing like a travel assessment on them, getting their allergies, getting their home medication. So we're asking them a lot of stuff. And unfortunately, we kind of put our HIV screening a little bit towards the bottom. I wish we could move this up, but at the same time, we have so many other very important assessments that need to be asked and gone over with that patient, just to make sure from a priority standpoint, what do we need to get you into a room right away? Do we need to get you to the CT scanner right away? Should we get a physician to lay eyes on you right away? So our HIV screen is kind of following some of the other screenings that we do along the list. So that HIV screen. So we ask it, this is the same question we started when we first went live with our HIV screening. And it's just that we give the patient the statement at Hurley Medical Center, we test all qualifying patients for HIV unless you say you do not want to be tested. You are free to decline the test if you'd like. And then the nurse just has to say, the patient does not opt out, which means they order the HIV test, or they do opt out, which means they do not order the HIV test. Or we do have patients that come in, they're just not at a capacity to opt out, so we won't be ordering the HIV test on those patients. So the biggest thing for us is in the very beginning, the wording like in parentheses, we had like, does not opt out or opts out. And everyone was like, okay, so does that mean, do we order it? Do we not order it? So we kind of had to make it a little bit foolproof for our nursing clinicians at the bedside to know like, okay, if you're not opting out, then you need to make sure we are ordering that HIV test. One other thing that's kind of important to know about this section from that triage section, if they've had a HIV test on file for the last year, just like Dr. Swar mentioned, then this section actually doesn't even show up to ask them the question. So we look back for a year of data, and if they have something on file, then the section won't even appear for them to ask the actual screening question. So that helped a little bit too, because some people were like, this patient just came in yesterday. I asked it yesterday. Why am I asking it again? So that was something from the very beginning as well that we needed to make an improvement on. So that way our nurses aren't getting burnout, hopefully, of asking the question. So then kind of going forward from there, after you ask the question, if the patient opts in, there is a pop-up that comes up and then you can order the HIV test once you're in the patient chart. And that HIV test looks just like this. It comes up and everything is kind of already pre-checked for you. So then you can just sign the order and actually put it in. So it kind of makes it a little bit foolproof. If you need to change anything, then you can go in there and change it. But everything is kind of just default to, yep, once today, we're going to do it. Yes, we can print out the actual testing brochure and give them more information if needed. And then for our nursing workflow, so this is from an ED, we use Epic here at Hurley. And so this is part of our ED narrator. It just pops up as there's a new order for our HIV screening. And then you just print your label and then you can do your blood draw and then you scan it and send it to lab. So it's a very easy workflow to do. But from a nursing perspective, I can tell you after just kind of collaborating with Dr. Swar, we have had some bumps in the road. So hopefully to get over those bumps, we've started to do a little bit more staff engagement. One way is always sending them their kudos via email. So that, we had an asymptomatic individual that was identified, and then we were able to start therapy on them. So just trying to keep the staff engaged, trying to make them understand this actually is a very important question. You can help people. This is something to try and keep putting the initiative in, because really from an ED perspective, we have very few days of downtime. So there's a lot of the times where you'll hear nurses say, oh my gosh, I'm just over triaging, or I'm overdoing this. And though we understand that, we need to keep them engaged and keep that compassion rolling. How can we keep them engaged? So this was one of the ways we kind of started to try and keep the staff engaged. But then here's the biggest question. So why aren't staff asking the question? We've had some report data lately that kind of shows us that some of our nurses just skip over this section. They're not even asking it. I've asked a few of those nurses, like it shows out of the 50 patients you triaged last week, you only asked the question 24 times. And some of them give me answers like, oh, I just didn't want to answer it. And I'm like, well, that's not really a good answer. So we kind of go back to the drawing board of like, how can we get staff to ask this question? So one of the things we started to do to try and improve it is Dr. Suarez started a really good initiative of doing audits. So having reports made from our Epic and just kind of showing us, so which nurses are doing really good at asking and which nurses are not doing so good at asking. And then we can kind of target them and ask them, why aren't you asking this question? And what are you doing to actually make sure you're asking this question? We have one registered nurse here that he does an amazing job. His name's Tommy, and we were really hoping he could speak today, but he always makes sure he asks the question. And he's like, it's part of my triage. I ask it, I make sure it gets done. And like just hearing him say, it's not anything extra for him. He feels like it's just part of the workflow. It goes easy and he can ask it. It's kind of reassuring us like, okay, we've got a pretty easy workflow built in, but how do we keep all those staff and get them engaged? So here's kind of the caveat to us. So we've had a high staff turnover, especially since COVID, and we have a very young staff. So just trying to keep the turnover to a minimum as much as possible. We're feeling a little bit more staffed as possible, and then just continuing that education. So doing those audits, trying to educate the staff, and then trying to make sure we have some leaders on the floor. So RNs like Tommy that make sure that he's always asking it. And then how do we get those engaged that aren't asking the question? And when I've questioned some of those nurses that aren't asking it, some of them are like, well, I don't know the answers to the questions that the patient might ask me. So one of our newer nurses, actually, her name's Ashton. I just talked to her recently, and she's like, well, I didn't ask it because when I went to ask it, the patient asked me, well, how much would this cost me? And that kind of goes back to like what Claudia was saying earlier. Patients really worry, is there going to be a financial burden associated with this? And if we don't give the nurses and the clinicians the tools to say, okay, this is from our experience, and if we have the insurance cover it, and we're running it through the emergency department. So just giving them the tools to give those patients the answers to try and make sure they can get these routine tests done. So our biggest problem truly has just been trying to make sure all the staff stay educated on why we've started this initiative, how to keep them engaged, and how to keep it going. And the biggest way that we have been able to really continue this is like through our audits and trying to keep the staff engaged. So I know I kind of went through that a little fast, but hopefully it helped answer some of the questions that I know everybody had about the question that we ask. So if there are any more questions for me, just let me know. But that kind of concluded my part that I had from our nursing perspective.
That's great, Jenny.
Yeah.
And I don't want to shortchange the question from Jennifer. So I want to go back to you. You able to come off mute and
Yep. My
perfect.
name's Jennifer, and I have a question and a comment. My question is from earlier about the routine um HIV. That question was why can't you have like rapid, is it just a matter of time that rapid results aren't, you're not able to do that? So the patient knows before they leave. And then that's one question. And my second question is pretty much like pertaining to the presentation that just finished. If I were a patient in ER, I would not like to hear the words, you qualify for HIV test. I would like to hear something along the lines of, for the health and safety of the community, we're adding free, like if I hear the word free, like free screening for free of charge, something for HIV, COVID, and flu screening. Are you interested? That's it. But if you tell me you qualified, that would hurt my feelings and make me think like, well, how am I qualifying for, you know, like the guy came in, the example came in earlier about he's coming in for chest pain. And then he's like, how do I qualify for HIV screening? I'm here for chest pain. That don't make sense.
Gotcha. I think I can answer both of those questions.
Sure.
The first is that a rapid HIV test, ones that are done at the bedside or ones that are expedited, is a different test than the HIV test that we do for our screening test. And one of the
Okay.
differences, other than time, is expense. It's a much more expensive test.
Okay.
It is done when we need to rapidly identify a patient with HIV in case of a healthcare worker exposure or other sort of very select circumstances. And so giving everyone a rapid HIV test for our particular health system would be a non-starter in terms of like the practicality and the cost.
Well, I thought
Okay.
not you personally saying that. I heard something being addressed in there about cost and.
So each test that's done in the emergency department has a cost, has a facilities fee, and has another series of charges associated with it. And our health system does not do rapid HIV tests unless knowing the results at that moment is going to change the immediate treatment for the patient.
Okay.
So, and the reason for that is because even though it is fast and we love fast answers, especially in the emergency department, trust me, all of us want the answers right now. It is not a cost-effective way for us to do that and still keep the program afloat. You know, having a test covered by insurance doesn't necessarily always mean that 100% of the cost is covered. It just means that insurance agrees to pay for whatever it is they agree to pay for. Just like when you get an insurance bill and you've had a $500 visit and you pay your $20 copay and you get like an explanation of benefits that says the insurance company was billed $500 and they happily paid, you know, 207 and now you have $0 in charges. So a little bit of it is the way the system works. Additionally, the turnaround time on our screening is somewhere between 1 and 3 hours based on the screening we do, not the rapid HIV, which is generally a pretty fast test as far as blood work goes especially in the emergency department. So many of these tests do come back positive. I do love hearing about your concern for screening. I've, in my experience, actually had most people kind of just sort of shrug. Like I say, you know, hey, you are eligible for HIV screening because we screen anyone between the ages of 18 and 65 who hasn't had a test in 12 months. Can I add that test on? And they go, sure. I would say that is the response, and not the response I expected when I started this program, but most people are like, hey, you're drawing my blood, do the thing. And even if they do initially feel offended, it gives us an opportunity to discuss with them why they're eligible, basically just because the CDC says everybody should get a test at some point in their life.
Mhm.
And it also helps, even if initially they're not ready to take on that test and to allow it, hearing this over and over again decreases the stigma of HIV testing, of HIV treatment, of the disease within the community. You know, instead of, do you want this? We say, we do this for everybody who's eligible, and everybody's eligible. You know, do you want to be like everybody else? And who doesn't want to follow the crowd, right?
Why
Thank
was
you.
the person that had the chest pain, what made them eligible?
Anyone between the ages of 18 and 64 who comes in through the emergency department and has not had an HIV screen in our electronic health record in the past 12 months
Okay,
is eligible for testing.
okay, thank you.
Yeah, I'm going to write down
Thanks.
some of that feedback about the how to word it. Thank you very much.
Thanks.
Thanks, Jennifer. I'm mindful that we only have a couple minutes left and I see one more hand up. So I guess the other Keith, if you're available to ask a question.
Yes, good afternoon,
All
everyone.
right, thank you.
I do have one question, and I don't know if this can be directed to Hurley or just other emergency departments. If there is rapid testing available on site, and just like the lady just mentioned, there's a window of an hour and 3 hours of them receiving the results. Are there same day preventative services available? I.e., PrEP, PEP, antiretroviral therapy, even though you all don't provide specialized care for individuals with HIV, having programming or funding supported for those who may not test for HIV or those who do test for HIV and getting them engaged in treatment immediately upon getting that diagnosis. Are there any emergency departments available in the state that does provide that?
That's a great question. I don't know of any emergency department that has a program that provides NPEP or PrEP. I think every emergency department is aware that it exists. I think for Hurley's point of view, we're not there yet, but it's on our radar. I think there are a lot of resources through the health department where if a patient were to come in and ask about non-healthcare associated post-exposure prophylaxis to HIV, we actually have orders and we have resources available so that the emergency physician can order those tests and determine the appropriate treatments and appropriate medication. And we have not truly broached any PrEP in the emergency department yet.
I'm noticing it's the top of the hour. I'm sorry we have to shortchange any further comments or questions, but I want to be mindful of your time. Certainly, though, if you have follow-up questions, please reach out. I think Sam Kesterson put in some contact information to our program already in the chat. I also want to note some programming it's upcoming as we continue this learning series. The next one on the books is in August. We're going to be talking about actually some of this topic around the particulars of the lab testing and the sort of functionality around that, capabilities around that, interpretation of those tests. We do think that's a knowledge gap that could be worthwhile. So please put that on your calendar. And then please, if you haven't done the survey, here's the QR code for that. And then finally, if you're interested in continuing education credits, we have a process for getting those credits to you as well. Just be knowledgeable that there's a 1 week window in which you need to claim those credits. We work through the University of Michigan to do that process. So please be aware of that. I really appreciate your questions, your time and attention, and your ongoing engagement, and look forward to connecting with you guys in a couple months. Thanks so much.